Hi, this is the ISDE panel discussion on eosinophilic esophagitis. I'm here with a group of experts. My name is Arjan Redenoord, gastroenterologist from the AMC in Amsterdam, and I'm here with four people.
David Katzman from the Mayo Clinic.
Ego Verano, Northwestern Chicago.
Imogen Feldman, Northwestern Chicago.
Alex Straben from Switzerland. Glenn Peruta, Children's Hospital Colorado and University of Colorado School of Medicine.
Thank you. We'll now discuss several questions and topics on eosinophilic esophagitis. And my first question I'd like to ask Professor Katzka, Mayo Clinic. So, Professor Katzka, the patients with EOE now often need repetitive endoscopies with biopsies, which is obviously burdensome for the patient and very costly. Do you think that there will be less invasive tests for diagnosis and follow-up of EOE in the future?
Thank you, Dr. Redenoord. I think it's really a matter of time. I think there are a lot of exciting types of tests which are being experimented with now to monitor EOE, which should be as accurate as endoscopy. I think starting from the least invasive test, there have been several studies with urine and blood which show promise and certainly higher levels of various proteins in patients with active EOE, although not ready for prime time, that shows promise. And then there are tests which avoid endoscopy altogether yet sample esophageal tissue. One of the tests developed by Dr. Glenn Peruta on this panel is the esophageal string test, which can sample esophageal secretions and is very easily performed, well tolerated, and as a children would be very effective. There's a cytosponge trial device used for Barrett's esophagus, which samples the esophagus swallowed in pill form and gets a robust histologic sample. Early results with this technology show that it could also replace perhaps endoscopy in time. And then there are tests performed during endoscopy itself, which may not be needed for biopsies. Techniques such as esophageal impedance, which are probe-based technologies that can measure the dilation of intracellular spaces in the esophageal epithelium as a reflection of disease activity. This is done quickly and easily and avoids the cost and potentially invasive nature of multiple biopsies that we have to take. There's some other interesting avenues being explored, even genomic analysis of blood to determine whether patients are in remission or not. So although none are quite ready to replace endoscopy and biopsy at this point, I think there are a lot of exciting possibilities on the horizon.
Thank you. Dr. Urano, do you think these new tests will be mainly used for diagnosis, initial diagnosis, or more suitable for follow-up of patients?
I think the tests right now, the way that they're being positioned is for use for follow-up. For patients who require serial testing, most commonly in the setting of diet elimination reduction therapies, I don't see them replacing the use of standard endoscopy with biopsy for the initial diagnosis.
Thank you. Now, there's another big issue in EOE, and that's to what extent do we need to exclude other diseases in a patient with suspected EOE? So, to what degree do you need to exclude gastroesophageal reflux disease or PPI responsive eosinophilia? So, Dr. Peruta, would you like to comment on that?
Certainly. So the diagnosis of eosinophilic esophagitis is really based on having symptoms and an abnormal biopsy. The biopsy is characterized by increased numbers of eosinophils in the esophageal mucosa, and that can be seen by a variety of different other diseases, including reflux disease, celiac disease, Crohn's disease, infections, drug hypersensitivity reactions have all been associated with that type of inflammation. Probably most intriguing now, and something we are continuing to learn more about, is this entity in which patients may respond to proton pump inhibitors and as either an anti-inflammatory or as an anti-acid properties of that medication.
Thank you. And Dr. Urano, what's your view on that?
Yeah, I think in general, there's a very stereotypical presentation in our adult patients that have eosinophilic esophagitis. So I think very few of them actually require a lot of extensive secondary evaluation for other causes of esophageal eosinophilia. Patients, as we all know, are patients in their 20s and 40s who present with stage of food infection, often with atopic history, mostly male patients. And they have very stereotypical endoscopic features in over 95% of patients. The rings of varus exudates and venous stricture formation. So if you have that constellation, typical demographics, typical kind of clinical presentation, typical endoscopic features, I think there's very little need to do an extensive, exhaustive workup for these listing of secondary causes of esophageal eosinophilia. Many of the things that Dr. Fruta mentioned, such as achalasia or collagen vascular disease, scleroderma, hypereosinophilic syndrome, Crohn's disease, are things that are going to be readily apparent on your clinical history. So again, I don't go through an exhaustive diagnostic evaluation for the majority of the patients. The one, bugaboo has been gastroesophageal reflux disease, and that's continued to vex us even to this day. How to properly evaluate for that. There is an overlap in terms of the symptom morphology and also the histologic manifestations. So I think that's something that's continued to be discussed.
Okay, thank you. So we'll talk about dietary treatments now. So Dr. Gonzalez, you published about the 6-food elimination diet, and it's the most used diet for EOE, but it's also considered cumbersome sometimes. What do you think is the future of dietary treatment for EOE? Does it have a future? Is it the 6-food elimination diet or something else?
I think the evolution of dietary therapy is really exciting right now, in that we know that adult patients and children can both respond to dietary therapy. The 6-food or empirical elimination diet has been one of the most common approaches, but as you pointed out, there are definite limitations in that we're taking away all 6-food antigens up front. So there's a lot of movement to try and make the diet a little bit easier for the patient population. And knowing the most common triggers are milk and wheat and soy and egg, there's been a movement to doing a 4-food elimination diet, which has been effective. And now even a stepwise approach by Dr. Lucendo, looking at the common 2 foods. So really trying to taper down the dietary elimination to make it more accessible.
Does anyone else want to comment on that?
I think that the children who have eosinophilic esophagitis may in fact be readily more adherent to this type of approach because they are having parental supervision, so certainly young children may be impacted by dietary modification. As they get older, it may not be as easily adherent to.
Just one other plug, I think it's something that I think many clinicians don't offer in their practices. They view it as very difficult for patients, but actually if you bring it up with your patient, it's surprising how many of them find it very attractive to treat their disease non-pharmacologically with a dietary approach. And many of our patients are already doing diet therapies for other things. The gluten-free diet, for instance, is become a big fad in the United States. So I think there's a lot of appeal if you actually bring it up with your patient, discuss with them the pros and cons of diet approach. It's amazing how many of them actually will choose diet therapy.
Now this panel discussion wouldn't probably be here if EOE wasn't, the incidence of EOE hadn't increased that fast over the last 15 or 20 years. Dr. Straumann, you're one of the first to describe this entity. Do you have any idea what's the underlying cause of the increasing incidence?
The first question is it indeed a real increase in the incidence of the disease, or is it an artifact because we are now trained, we know the disease, and we diagnose it more frequently because we know this animal? I think we have good evidence that one part of the increase is due to the better awareness. But I'm convinced that a real increase does exist because the peak manifestation of EOE, the food impaction, the long-lasting food impaction, was decades ago an absolutely rarity in cancer or in a severe peptic stricture, but in a patient with a normal-sized esophagus, in a normal food stuck in the esophagus was an absolutely rarity, and now we see it all day. Therefore, I think we are confronted here with a real increase in the incidence. And now the question is why? I think we agree that EOE is an antigen-triggered disease, likely a food antigen-triggered disease, and we have to focus what happened with the food production during the last decades. I'm personally mainly interested in milk, because milk is based on the results of the 6-food elimination diet studies, where the leading culprit food category, and because I'm coming from Switzerland, and we have a milk tradition, and if I see all has changed during the last decade in the milk production, I think we have to focus on this. I basically assume that in the production of the food could be an important clue to this answer.
It's a bit of a provocative statement. Does anyone like to comment on that? You, Dr. Gonzalez?
Yeah, no, I think Alex really raises some very interesting points, and our food chain and how food has been developed over the last 20 years has changed substantially. Milk and wheat, as we know about here in the U.S. So there's certainly some interesting speculation that that's what it is. I think, EOE is also an allergically driven disease, as you pointed out, and it's what we call Th2-driven disease. And it really mirrors what's happening in other allergic conditions like asthma and food allergy, which have been rising exponentially.
But I think it's too simple to say all allergies have increasing incidences. This hygiene hypothesis is for me too simple. I think we have to look more from the causative food categories, what happened during the last year.
There might be a causative or continuing role for microbiome also. I think that's something that's becoming certainly more addressed now. It's being measured within the esophageal microenvironment, and whether differences in deep disease states or it's altered by antibiotics or food itself may be one of the contributing factors.
Okay, thank you all very much. I'd like to thank the authors, the experts for participation in this expert panel, and I'd like to thank you for watching. Thank you.